Well, hi, welcome everyone. Good afternoon. Buenas tardes. Hope everybody's doing well today, or good morning, buenos dias, depending on where you are in the world today. We're gonna give it a couple of more minutes for other folks that have registered. Give them a chance to transition and join us. In the meantime, if you're so kind, we would love to have folks go ahead and introduce yourselves. I believe the chat is enabled, so we're gonna try it out right now. And we're gonna ask folks if you can to introduce yourselves in the chat. If you want, put your name, where you're joining us from, and if you're affiliated to a particular group or organization and you feel comfortable sharing that as well. And welcome everyone. Buenas tardes, buenos días, bienvenidos, welcome. I see San Francisco here. Welcome, thank you everyone. Oh, we have friends from North Carolina, Canton, yeah, Montana, awesome. Los Angeles, we have another friend from Cali, yeah. LGBT Center, awesome. Indiana, Tennessee. Juba Harm Reduction in the house, welcome. Washington, Everett, Washington, welcome, folks. San Diego, great. We have friends from Ohio too, and Virginia. British Columbia, oh wow, awesome, welcome. Rutgers University, New Jersey. Hola, hola, Karina, bienvenida. Welcome, Stanislaus, yes. We have Pennsylvania in the house too. Seattle, welcome, folks. Orange County, awesome. Beverly, Massachusetts, yay, my old stomping grounds, Massachusetts, many years ago. Atlanta, Michigan, awesome, welcome. Oh, another friend from Michigan, awesome. More North Carolina and Virginia folks. We have folks from New York City representing. Bienvenida, Francisco. San Diego. St. Cloud, Minnesota, yay. Another friend from Canada. Tenemos a Chicago in the house, and Colorado. Awesome. Welcome, Christopher. We have friends from Seattle. Milwaukee, yay. Arizona, Kentucky, wow. South Carolina, Texas, it's awesome. Hey, Brett. Reno, Nevada. Northern Kentucky. Wow, that's fantastic. We're gonna give it one more minute. Eureka, California, yay. We have another friend from Colorado, San Francisco. Greenfield, Massachusetts, Tammy, I used to live in Northampton. Oh my God, it's great to have someone here from Western Mass. Many years ago in another life. Many moons have passed. Welcome to our friends from Livermore, California, y Texas. We have friends from Plumas County. Yes, Jamestown. Sacramento, Knoxville, Tennessee. Southern California, love, absolutely. British Columbia again. Fantastic. Oh, this is so great. I'm always really excited, as I said before, to see all these names come through. I'm scrolling. My finger's gonna get a workout. Awesome. Well, I think we can go ahead and get started as other folks are joining us. This is fantastic. Thank you so much for introducing yourselves and for being here. I'm gonna start off by introducing myself, and then I'll kick it off to my amazing colleagues who are here. If you were in our previous webinar that happened 2 weeks ago, you may have met them already. If not, you're in for a treat. My name is Tanagra Melgarejo Pulido, and I am part of the National Harm Reduction Coalition, and I am really excited to be here with all of you today, also with my amazing colleagues, to explore together this intersection of trauma-informed care and how do we work with people who are living with co-occurring disorders, And how can we best support folks in our communities, folks that we work with, whether they're our patients, our clients, our participants, our friends, our family, our colleagues, and our neighbors. So I'm gonna pass it to Taylor to introduce himself.
Thank you so much, Sanagra. And hi, everybody. I'm seeing the numbers steadily climb, and I'm like trying to figure out where everybody is from. Detroit, saw a lot of New York in there. It's amazing, and I'm sure we're going to get a lot more people joining. So my name is Taylor Edelman. I use he, him, his pronouns. I've been working here at the National Harm Reduction Coalition for almost the last 3 years. Shout out to Harmony. Our 3 years coming up on Monday. Very excited. But specifically here at NHRC, my job is to oversee the Lighthouse Learning Collective program, which is our New York-based, New York City specifically based program that focuses on queer and trans people who use drugs and also engage in sex work. So if that's of interest at all, you're interested in our offerings and trainings, publications, I can put my email in the chat. You can reach out to me, or you can navigate to harmreduction.org. And you can take a look at toolkits, different reports we have, guides, everything that's free and open and available for you all. But very excited to be here and seeing some familiar names in the chat. Welcome.
Hi, everyone. My name is Harmony Seberg. I use she, her pronouns. I am the National Program Coordinator here at NHRC and based in New York City. I will be in the background today, so look out for me in the chat. Also, if there's any questions, Q&A is a great place to go if you don't want to get buried in the chat. But yeah, let me know if y'all need any support. I'm excited to see all your faces here. We have 406 people in the room right now. Pretty amazing.
Thank you, Harmony. Thank you. Taylor, just to get us kick off this session, this webinar, just to give you some context, we're going to be presenting, and then we always are excited and happy to take questions from folks. So if you, as Harmony said, if you have an urgent question that you want to ask, go to the Q&A. If not, we'll try to monitor the chat. Definitely for participation, we ask folks to use the chat. And then we'll have some time at the end of the session where we'll stop sharing our screen. So hopefully you can see our faces and we can hear you. You'll have the ability to unmute yourself, and we can take some questions and have some discussion. So just to give you some idea of how, at least some of those logistics. But in terms of this trainings, I just want to name that we have been funded through a partnership with the American Association of Addiction Psychiatry and through the Opioid Response Network to be able to provide these trainings. ORN, that network, provides technical assistance. They are excited and happy for you to reach out and to inquire about submitting a request, both for education and training. They can either connect you to your technology transfer specialist for your particular region. Each region has one assigned, or they can look into the sort of pool of subject matter experts. National Harm Reduction Coalition is one of them. And you can reach out to them, and then you can get partnered with us to be able to provide you further training and technical assistance. So if that's something that interests you, we will share with you here, and I will share the slides. You'll have access to these. You can write to them at this email, or inquire directly by visiting their webpage to submit a technical assistance or training request. And at the end of this session, again, we will remind you, but we really appreciate your feedback. And Warren also wants to hear from you about how this session was for you. So please, we invite you to complete this evaluation survey. There's a QR code there that will direct you to the survey. There's also a link. Again, you'll have access to these slides, and you'll be able to you use either the QR code or the link to complete the survey. And now a little bit about us. For those of you that are here that may not know who we are, the National Harm Reduction Coalition started 30 years ago. It's an important number for us, and it was founded and established by people who use drugs, who were living and fighting in the midst of a pandemic at the time, which was the HIV/AIDS pandemic. And they were not being included in conversations that were happening at the national, state, and local level in regards as to how to best address that pandemic. And that pandemic was impacting them, their community, and their people were dying. And so we did what we do best, which is organize and demand a seat at the table, to be included in those conversations, to have a part of figuring out the best way to respond to that pandemic. And out of that, we were born, and we continue to do this work of training, capacity building, advocacy to really address and create spaces for dialogue and action that can help us, heal the harms that have been caused by racialized drug policies. And we do that through all of these different avenues here: trainings, capacity building, technical assistance, as well as resources and publications. Invite you to visit our webpage, check it out. We have tons of materials there that we have created in hopes that folks will be able to use them. So the only thing we ask is, if you are downloading them and adapting them, that you just give us credit. But otherwise, we want you to use them, because what good is a document or a material that we create if it sits there and it's not alive and people are not using it? Another thing that I want to share before we start the session is that language matters, right? And we know that language, the words that we use, can help us connect, build relationships, be able to meet people where they're at, give us the space to build bridges for collaboration. And language also can hurt, right? And can do the opposite of that. It can actually help us, create a chasm between one another. And so in the case of this training, we want us to think about using language as a way of bridging gaps and to create spaces for connection, and to really center the fact that we're working with people, with human beings, right? And that language can help humanize, and it also can dehumanize. And in the case of this session, we want to invite all of us, myself included, to really try to work from a person-first space and person-first language. So when we think about, people who are using drugs, think about that, people who use drugs. Instead of using terms like addict, which have a negative connotation, can have a stigmatizing connotation when we're thinking about, substance use in general. Using substance use instead of substance abuse or addiction, because again, we're adding a moral weight to a behavior that the person is engaging in. And most of the times it's our own, right? Moral weight. And finally, when we're addressing thinking about mental health, think about mental health conditions instead of illness or disorder, right? And some of our participants may use those terms, and we can create a space of discussion and conversation. And I always feel it's great to be multilingual and to be able to use access to different language that is fitting and helpful in different spaces, right? It's not the same for a participant that I work with that trusts me to, in the context of a meeting, right, to say, oh, I say I'm an addict, that to say that in front of a doctor or to say that in front of a judge, right? Because that judge will not necessarily be able to do the translation in their head the way that some of us can, right? And so I always want to set up participants to succeed. So the more access to broad spectrum of language that they can have and use, the better that is for all of us. So a little bit of an invitation for us and for myself to always try to use person-first language. And now we're gonna get started, and we're going to ask folks, if you are so kind and you can type in the chat, what are some of the reasons that we use drugs? Why do people use drugs? It's gonna be fast, so I'm gonna try to do my best to read it, all right? So to cope, to self-medicate for pain, to soothe physical pain, to navigate stress, to feel better for our mental health, to feel good, absolutely, Trudy, to feel safe, yeah, to cope with the world that is around us, to mask emotions, to escape problems, particularly world problems, to feel good, to alleviate pain. Let me see what else. Because it feels really good, absolutely, yeah. They work, and they work well. To help us relax, to navigate mental health conditions, because we want to, absolutely. For some of us, it's to address burnout. Let's see, to feel good, for trauma, mental and physical pain, for survival, absolutely. Let's see, some of us are grieving, and using substances can help us through that process. To socialize, Alexia, absolutely, yeah. Some of us, I'm very shy, an introverted, believe it or not, and there's nothing like a little social lubricant that is helpful for me when I'm feeling stressed out to be in a social situation. So definitely I can look at substances as a way that can help me address that. Absolutely. Numb our feelings for some of us is to connect with our feelings too, right? Like I want to feel that connection, as Mariah is saying, find connection to self and to others. Let me see, for anxiety, to have fun, to party. Yes, absolutely. This is great, folks. Thank you. Let me see. For fun, I see a lot of fun too, because we enjoy the feeling. It makes us lack of healthcare access to other medications, prescribed medications, absolutely, Sarafina. Or sometimes we're getting the medications prescribed, but they're not necessarily the medications that we need, or they're not working for us, right? We haven't really figured like the ¿cómo se dice? Oh my God, the prescription is not necessarily the prescription that we need. And so substances can help us navigate some of that as well. Yeah. For fun, to feel normal because they work. Great, absolutely. Thank you, everyone. Now I'm going to ask you another question. And that question is, why don't we stop using drugs? We know why we use. Now, why is it that we don't stop using drugs? And let me see. Let's see if I can go back down here and see what folks are saying. Okay. Because we have developed dependency, because we don't want to experience withdrawals, which are not fun, because we have developed a dependency, right? The same reasons that Damonte, absolutely, yes. We're gonna look at that in a second. Because they're part of our way of socializing. They have become part of our day-to-day routine. Because we have a chemical imbalance, there's shame and stigma associated. Because we don't have other resources or coping mechanisms, right? We haven't been able to explore or try out, or we don't know that they're out there. Because it causes a huge interruption in life. Absolutely, Erin. It's a disruption when you have a system in place, right? And then I'm being asked to shift completely the way that I frame and structure my day to day. And that can be really destabilizing and harmful for people, absolutely. But we don't want to feel what we're numbing because they're very much accessible, because they give us comfort, because we don't want to and we don't have to and we don't feel we have to, because we feel fear of what would be behind stopping the use. We can feel pain, we can have withdrawal symptoms, right? And sometimes there's no good place to have those managed. Because yeah, if you stop using them, you feel like caca. Absolutely, yes, Erin. Because the reality that we have facing in front of us sucks, right? So we don't want to see that reality, and we're talking about everything that's happening in the world, right? Sometimes it's like I need to disconnect. I need to unplug for a minute, and substances can help us with that. Let me see, because it can be scary not to have them around, because we know they work and they function, and we know that they do work and function. And the other stuff you're telling me, I don't know if that's going to work. So it's kind of scary also to contemplate or consider a life without something that I know has worked for me so far. It feels unsafe to stop. There's a ritual, as Madeleine is stating, around our substance use. We may not have access to resources to help us consider shifting, changing, or restructuring our substance use. And it may be tied, as Max is saying, to survival. We may need them to survive and to stay safe in our community. There are changes in our brain that happen, right, when we use substances, and some of those changes may have some degree of permanency. So what does it mean for me to stop using? It helps, etc., etc. Great, it's fun. I see this here, fantastic. Absolutely, thank you everyone for sharing in the chat box your thoughts around this. So as someone said already, there are 446 people in this room today. I can't see you all, but I know you're here. And most likely, we have 446 reasons for why we will be using drugs, right? And I think the importance piece here is like the same reasons we use are very much the reasons why we don't stop using. And in harm reduction, the important piece to remember is building that bridge, creating that space for connection. So what we want to do is when we're working with program participants, with clients, with patients, with people in our community, is to create a space that feels safer and free of stigma, where we can look at the factors that surround our substance use and brainstorm with participants, clients, patients, and community members options that they may know are available to them to reduce risks for potential disease or fatal episodes. So we want to create a space for conversation where people feel that they can be their full selves and bring their full selves to the table and really explore, if they're open to it and they feel they need to, their substance use, and explore what are the behaviors surrounding their substance use and what are some of the tweaks that they could make to make it safer for themselves, so that we can avoid fatal episodes or disease. And we can do that if we apply a harm reduction approach, right? And I love harm reduction because not only harm reduction gives us the space to really connect with people as human beings, but it also gives us so many opportunities to practice different strategies, right? It gives us a spectrum of strategies that we can discuss and explore with people that we're working with. And those strategies can help folks reduce negative consequences that may be associated with substance use, with sex work, or other behaviors, right? And we can do that through exploring safer techniques. And safer techniques in harm reduction can go from having access to new sterile equipment, right, if they're using, to having access to condoms, to lubrication, to having access to smoking kits. Safer techniques also can be having access to test strips or having access to naloxone, maybe being connected to folks in communities. So if I'm using alone, I have someone that can show up for me in case something happens, et cetera, et cetera, et cetera. So there is plenty of safer techniques that we can think of. And then there's managed use. And that is the space where people are thinking, considering, exploring the possibility of shifting or changing their relationship to a particular substance. So it may be I'm using less, or I'm only using at certain times of the day, or I am choosing if I'm going to engage in polysubstance use, or I have engaged in polysubstance use, I may reconsider how I do that. I may change the route of administration of the substance. All of those things can fall into that managed use bucket. And then we have abstinence. Harm reduction believes in abstinence and supports people move towards abstinence if that's their choice. Because we know that forcing people to do things sets them up to fail. Because many times when something is being forced upon someone, it's not something that the person can sustain in the long term. So what we want to do is support people to move towards abstinence because they feel ready for it and because they want to explore it, because the road towards behavior change, and all of us that have engaged in behavior change know this, it's challenging, it's not easy, right? So what makes it easier is that I want to do this, because when it becomes hard, I have a support system and I have the power and the desire in me to keep moving forward, right? So the other piece here about abstinence is that people get to define what abstinence looks like for them. Abstinence for me, Tanagra, it's probably very different, my definition, than the definition that some of you may have in this room, and that's perfectly fine. Because harm reduction is about meeting people where they're at, and about meeting people where they're at and working with people in terms of what they're feeling and experiencing in the moment for them, for themselves, right? And in this case, we want to work with that person, basing our work with that person's definition of abstinence and giving people room to explain to us what that looks like for them, because it can help us better support them moving forward. Harm reduction is also a movement. Remember, I started telling you a little bit about National Harm Reduction Coalition, right? And so harm reduction comes out of people who use drugs organizing themselves to take care of their communities, their loved ones, and to take care of us. Because harm reduction is a gift that has been given to us. This framework has been given to us so that we can continue to take care of each other, right? So harm reduction as a movement believes that you don't have public health if you don't focus on sustaining well-being for people. And well-being is housing. Well-being is access to medications. It is access to treatment. It is access to medications and treatment that really take into account the intersections of people's identities, right? It's so powerful for me as a Puerto Rican woman to be able to go to a therapist that speaks my language, that is part of my culture. You don't know the difference that that makes for me, because she understands me, right? We can connect on a level that makes a huge difference for me as a human being, right? And to be able to access that is really, really powerful, right? So that is well-being. Well-being is access to food, it's access to employment, right? It's access to education. It is access to community, to participation. All of those things are part of well-being. Well-being is being able to be us. For me to feel safe being me, being all of this, who I am, right? And we know that without that, we don't have public health. Public health also means that we're fostering health and liberation for people. If people have access to healthcare, that is the first step in helping people be able to be autonomous and be free and be safe and secure. So healthcare is important. Public health, well-being is important, but this goes beyond that. We want to really make sure that we're addressing the barriers that are preventing people from accessing the services that they deserve to access. We know that the barriers that most of the time our participants and many of us may face have to do with stigma and criminalization. And those are the real reasons of harm for people many, many times, right? When we criminalize, we stigmatize and we dehumanize people. And that pushes people to the margins and to the places where people are unseen and unheard. And that's where the harms thrive. And that the only way that we can change all of these things, that we can have well-being, that we can have public health that really responds to the needs of community, is if we center the voices and the experience and the expertise, but most importantly, the leadership of those that know what it is because they are living it day to day, the leadership of those most impacted. If we follow that leadership, we will be then moving towards creating transformative change. So this is why harm reduction to me is such a powerful framework to work from, because it's really giving us the blueprint to be able to shift and transform the systems that we're working in and under to be able to better serve us and to serve our communities and our participants. And for that, we have the principles of harm reduction. There's 6 principles here. If you go to our webpage, if you haven't visited, but I'm inviting you twice that I'm doing the plug for the webpage, you can find our principles there and you can find these principles very much well explained. And so if this is the first time you're seeing them, I invite you to go and visit our webpage so you can learn more about them. But the principles of harm reduction are the underpinnings of our movement, right? These are the guides. This is what I every day try to center and work from in order to be my best self as a harm reductionist. I try my best every day. Some days are better than others, right? But the most important thing here is that participants are the key and core of this, right? We have to really ensure and explore. Thank you, Taylor. How do we provide participant-centered services? What does that mean, right? We cannot provide participant-centered services if we don't have participant involvement in helping us figure out how do we do that. And in order to have participant involvement, we have to respect participant autonomy and understand what that means, right? We also, if we do that, if we engage from a framework of autonomy and really truly involving participants as equitable partners, as subject matter experts in the process, we're creating spaces to uplift the health and dignity of our people. And if you don't have health and dignity, if you don't explore and understand the social cultural factors that may be creating barriers or impacting a participant's ability to be able to engage with us, to access services, to live freely, and to be safe, right? So thinking about those intersections of identities are really, really important. Like, how would you work with me, Tanagra? A bisexual Latina woman who's middle-aged, right, who lives in Puerto Rico, whose first language is not English, right, who's Spanish, whose parents were immigrants and is first generation in this country, right? All of those are social cultural factors, right, that are part of who I am, and that like also create spaces for access, but also for barriers for me in terms of being able to find services that really meet my needs. And ultimately, we want to be pragmatic and realistic, right? And that means that we know that there are harms that come from substance use, right? And we talked about the structural and social harms and other harms that can come from the drugs themselves. We don't have a regulated market, right? We don't have a way of really ensuring that what the person is buying on the street is safe for them. Now we're having people who use drugs started engaging in drug checking and really pushing and teaching themselves how to use drug spectrometers and how to be able to connect with people that have access to those, to be able to ensure that we can test the substances to figure out what they have so that we can be safer. And that's why we have test strips and all of those things. So we're pragmatic and realistic, right? And we know that. And we also know that if we don't continue to create spaces for conversation that are free of stigma, that are free of shame, we are not then able to support people the best way we can, because folks are not going to come to us to talk to us if they don't feel safe. So we're pragmatic and realistic about that. People are scared because they know that there is a great weight that they bear moving through the world as a person who uses drugs in a society that shames and stigmatizes and many times doesn't understand the reasons behind substance use. So as harm reductionists, we create a space where we acknowledge that, and we also work with people to help them be safer, because we are able to create that safer space for conversation and discussion and connection to resources. And we also, as harm reductionists, are committed to protecting, uplifting, and centering participants' personal autonomy. And for the sake of this session, we're borrowing from our colleagues in NASTAD, and some of you may have connected to what NASTAD is, this definition. And the way that they define it and the way that we would offer us to define it here in this session is an individual's capacity for self-determination and self-governance, right? So I get to determine, if I go to the doctor, for example, I get to determine if that medication that is being prescribed to me is something that I feel it's okay for me, or if I want to ask for a second opinion, right? I get to determine if I have something put in, by a medical provider. I get to determine if I were to get pregnant, whether or not I want to continue that pregnancy to term, right? I get to determine if I have tattoos in my body or not. I get to determine if I want to engage in X, Y, and Z particular processes, right? I am able, because I have the self-determination and the self-governance to do so. And so when working with people who use drugs, it requires all of us as providers, as practitioners, as accomplices, as allies, to respect the choices of the people that we're working with. It may not be the choice that I would make, and that's fine. It's not the choice that Tanagra Maria Melgarejo Pulido would make. This is not about me. This is about the participants, so that is okay. But it's essential that we respect the choices of the people and the person as their right, by recognizing that most often than not, we're trying just to do the best we can with what we have, right? And that's the piece of connection and community, right? When we can share with people, when they trust us enough to open themselves up, and we can explore with them other options consensually, right? Always consensually, other options, other avenues, other possibilities. I think there's someone that has their hand raised, Christina, and I think that we can either type it in the Q&A and Harmony will let us know, or if you can hold it to the end, that'd be great too. Let me know, Harmony, if you have the question for us. And then the other concept that I want to hold us, to like ask us to keep in mind before I pass it on to Taylor, in a minute to Taylor, not now, but in a minute. It's this concept of radical neutrality and acceptance. And this comes from Pat Denning and Jeannie Little, who are the founders of the Harm Reduction Therapy Center out in San Francisco in the Bay Area. And they're the original therapists that began infusing harm reduction principles and philosophy into their practice. They're the original harm reduction therapists. And they came up with this concept of radical neutrality and acceptance that we want to share with you if you're meeting it for the first time, because I have found it really helpful for me in my practice. This is another thing that I can look to ensure that I am doing things in the way that I want to do them as a harm reductionist, right? And it's asking us to consider that when we are providing services, we have to be willing to practice this concept of radical neutrality, which means that we're going to be grappling with ethical gray areas, right? Harm reduction is messy. Harm reduction is, it's like life. Harm reduction is like us. right? Harm reduction is like people. We are not, it's not black and white. Not everything ends up being wrapped up in a bow, perfect bow. Perfectionism is an illusion, right? That has been sold to us. Human beings are human beings, and life is not black and white. Many, many times, life is, it happens in the gray areas, right? So we have to be willing to sit in those ethical gray areas, because sometimes what we've been told, it's legal, in the context of this process may not necessarily be the best thing or the safest thing or the right thing for that person. It may be actually leading them to more harm, right? And I remember a case that someone shared with me of a person that was arrested. They were stopped on the street. They were an immigrant. They were in a process of navigating like their status in the US, and they were stopped, and they had a small amount of cannabis. And basically what the judge wanted them to do was to go to an inpatient 20-something day program, right? And this is someone that if they did that, A, they would lose their job, they would lose their housing, and B, we're not considering if this person needs that. Is that what they need, right? Do they have an issue of dependency, severe dependency with cannabis that may be interfering with their day-to-day life? None of that sort of like analysis was made. And so this decision was a cookie cutter decision that would have really negative impacts on this person's life and ability to be safer and healthier, right? So how do we explore those ethical gray areas? And we're open to doing that. It's also asking us to accept, understand, or challenging or difficult behaviors, right? Behaviors that may be foreign or new to us. We have to be open to that, to sit with our own discomfort. It's asking us to be taught by our clients, right? Because we relinquish this role of authority, judge, or expert. And ultimately, we want to do is to partner with our clients, right? Our clients can help guide us, and we can also provide input and insight to our clients in a relationship that is based on respect, and mutual aid and support, right? And so I think this piece of radical neutrality and acceptance is very much important when we're thinking of working with folks that are experiencing co-occurring disorders or are moving through life using substances, and also with mental health conditions. And now I want to share a quick video with you all, and would love to hear your feedback on the chat after we're done with the video. And then after this, I'll pass it on to Taylor. So I'm just going to share the video 1 second. Hopefully you can hear it.
Drug use is often associated with health harms. Infectious diseases such as HIV and AIDS and hepatitis C have clear links to drug use. There are also links between drug use and mental health problems that we need to consider. People with problematic forms of drug use often suffer from both a substance use and mental health disorder. The coexistence of a substance use and mental health disorder in the same person is usually called psychiatric comorbidity in people who use substances, or dual diagnosis. There aren't many figures on the extent of mental health disorders among people who use drugs, but the numbers affected can be very high, up to 80% in certain groups of drug treatment patients. Depression is the most common mental health disorder associated with substance use, but anxiety is also often seen, and comorbid substance use disorders are more common in people with psychosis. Compared with people who have only a drug use or mental health problem, people with comorbidity have more emergency admissions to general hospitals and to psychiatric hospitals, and more of them die by suicide. Substance use and mental health disorders are interlinked in different ways, which are sometimes overlapping. In some cases, a mental health disorder can be considered a risk factor for drug use, which may lead to the development of a substance use disorder. In other cases, drug use can trigger the development of a mental health disorder. Clinical practices also show that comorbid disorders often interact to make each other worse. It is often difficult to diagnose comorbidity among people who use drugs. For example, in a person entering drug treatment, acute psychiatric symptoms might be attributed to their drug use, or the effects of withdrawal or intoxication from drugs may be misinterpreted as psychiatric illness. Patients need careful diagnosis and integrated treatment, where the two disorders are treated at the same time with knowledge keepers from both fields working together. Providing this level of care is a major challenge for all parties involved.
Well, thank you for watching the video with us. I think the one thing that I want to uplift that is helpful for me in the video is a reminder of how siloed our medical system is and how piecemeal it is and how it's set up to pretty much fail people, right? In many, many levels. I always wonder out loud in my head with other people, why is it that we need healthcare navigators to help us navigate our healthcare system? Right. And it is a system that should not be overburdened. And the people that work within it are overburdened. They are traumatized and they are dealing with burnout and trauma and compassion fatigue. Right. And so it's a system that is failing everybody who is involved in it. And there's not a lot of good understanding about drugs because we don't have good drug education. Right. I've talked to friends who are doctors who have said that to me. It's like, in medical school, I never learned anything about comprehensive, non-stigmatizing, harm reduction-based drug use education that can help me understand why would someone use heroin. If I understand what heroin can do for someone, then I can understand what some of the reasons may be for someone to choose. And this is just an example, or cannabis or any other substance. And it can help us to approach that relationship with the patient from a more compassionate, curiosity, empathetic way, right? So I think for me, this video just is a reminder that we are working with a system that is very complex on purpose, and it is gatekeeping, kind of keeping people out and not really providing avenues for people to come in and have their needs met. I know some of us are here trying to change it, Ariana, and we need more people like you. I always love to have folks in the medical field that are doing that work, and we're here to work together and support you. And as a social worker, if I have social workers in the house, absolutely, we have to do our part in that system too. So for sure, it is it feels less heavy when we're doing this work together. So I'm just gonna pass it over to Taylor to take us through the next session, and I'll move the slides. Taylor, give me 1 second.
Awesome. Thank you so much. And thanks to everybody who's been putting questions in too. We see them, just so much activity. We're going to try to leave ample time at the end. And I'm also just fascinated by the chat. This has been a really juicy conversation so far. And I want to preface this next part because I feel like when we start to talk about co-occurring disorders, we start talking about the DSM, we start talking about things that are a little bit more clinical leaning, right? We can get into dangerous or kind of treacherous territory that maybe removes harm reduction from the conversation. But what we try to do with this is to infuse harm reduction in all aspects of when we talk about this work. And we view everything in a critical lens or under a critical lens, and that includes harm reduction, right? Because a lot of times people will say, as Tanagra beautifully demonstrated in the beginning, abstinence, that's not part of harm reduction. Clearly, it's part of it. It's not just on our slides, but it's in the way we practice it. I think I typed in the chat earlier when we talk about a lot of this work too, people think it's very this or that. And even with regard to substances, they don't realize that people have different relationships to different substances, and they can abstain from one and not the other. I know when I was a health navigator, right, trying to help people go through this really crappy system, and a case manager of people living with HIV and AIDS, this was a big thing, right? Some of them would abstain from smoking weed, but not alcohol, and vice versa, right? Or other things were going on. So anyway, that's my little spiel before we get into it. So we saw with the video talking about co-occurring disorders, talking about comorbidities, right? So essentially what we're talking about here is someone experiencing both a mental health disorder and a substance use disorder simultaneously. This is per the DSM, the big honkin' mental health Bible, if you will. So really talking about a combo of 2 or more SUDs and mental disorders, and that's how they identify it. Now, I will preface as well, because we did our slide in the beginning on language, really important to not just walk around throwing around the term substance use disorder at people. That is a clinically defined term with specific criteria involved in the DSM. Again, intent versus impact. I think many of us have beautiful, wonderful intent, and we want to save the world and do all the things. But sometimes we can really ostracize or push people away. We start to use language like that, or throwing around the word addiction, which is not in the DSM at all. It's a very complex, complicated term. And we're going to talk about this a little bit more when we get into kind of our continuum, if you will. But to give you an example of like a co-occurring disorder, I'm sure many of you already know this, but I think back to clients and patients I work with that were maybe manic or a major depressive. They had major depressive disorder, and they also were coping with alcohol use disorder, right? So they were experiencing persistent depressive symptoms, and they maybe turned to drinking as a way to cope, right? But that kind of exacerbated their conditions. It was kind of a chicken or the egg thing, and it became really difficult for them to manage. Or I think about some of the clients I work with who are not only living with HIV, they were using stimulants, they were smoking meth, they also had schizophrenia, right? And sometimes they were not medicated, sometimes they were, but all they needed was someone to just connect with them and really center them and hold that space instead of reducing them to their specific criteria in the DSM, right? They needed that wraparound care. So we can go to the next slide. So I also want to point out that these are really common, right? So as Samsa points out here, 21.5 million adults in the United States have a co-occurring disorder. And I think somebody had pointed out in the Q&A talking about older adults. So one thing I will say, because since you asked, although we don't have any one population that we focus on in this, I swear we could do a whole nother session on it. Maybe that's something that we do have to do. But one thing I want to say is I love that you pointed that out because there's not a lot of hard or great data talking about co-occurring disorders in adults, right? And we know that older adults, they are maybe isolated a lot more, right? Making it really hard to track those trends, to intervene, provide services, which also means that they're then using those drugs or substances, right, in isolation as well, which makes things really precarious and really dangerous when we talk about overdose, right? I also think about many older adults who are dealing with pain, their bodies hurt, right? Whether they were laboring away for their whole career or they're experiencing some other chronic decision, right? And I'm thinking about the way that opioids changed over the course of time, right? When we had these pharmaceutical companies making it harder to crush pills, right? People turning to the street, right? And then it just snowballed from there. And now we've landed at over 100,000 plus overdose deaths a year. That's not a coincidence, right? And a lot of times with older adults too, some of them might not identify as people who use drugs or feel like a lot of harm reduction education is geared towards young people. So it's not saying that any one community or population is more important than one another, but I think to kind of wrap it up, we need to talk about harm reduction in a way that's accessible for older adults, right? Tanagra does this wonderful training on cultural safety, and I think a huge part of that is also this component with older adults, right? But also, how do we integrate harm reduction, right, and substance use services into aging services? You know, senior centers, I think about like meal delivery programs, home health services, right, trying to reach people who might be using alone. And there's no shade in using alone. I know a lot of times we say like never use alone. The majority of people I know use alone, right? I don't necessarily think that that phrasing is helpful. Again, I think people have the best of intent, but I think that's also inherently stigmatizing, right? And then I think it's also peer support, right? Social connection, reducing that isolation. So I think those are some of the things I think about specifically with regard to older adults. So I hope that kind of answers your question. And I apologize that we don't have, you know, something more robust. But yeah, I just wanted to point that out because I love that point. We can go to the next slide. So WHO, shocker, right? So they say, according to them, health systems have not yet adequately responded to the needs of people with mental health conditions and are significantly under-resourced, right? Shocker, right? I know. So this gap between the need for treatment and actually doing it all over the world is often in poor quality when it's delivered. And kind of going back to the video and Tanagra pointing out that things are siloed, this is so much the case. I know we have specific programs. I work with a lot of them in New York City that do have co-occurring disorder kind of programs or facilities, but they're still not as common as I think we might like to see. But also a lot of times in there, they're not focusing on what we see here, these social determinants, right? So folding in education or vocational services, employment, housing, because I got to tell you, and again, this is probably not a shocker to people, a lot of what's driving this is that economic piece, that economic injustice piece, people just trying to survive and get by. This is something we talk about in a lot of my work with queer and trans people who are using, but also people doing sex work as well, as people are just trying to get by and live their lives and trying to cope with the reality around them. And life is hard, right? And that's exacerbated by having these mental health conditions, right? And then again, if you're trying to self-medicate, you're just trying to get through and you're being labeled as a person who uses drugs, you're being labeled with a word that I will not say, right? That is going to make you refrain from wanting to go and get care and get treatment, right? So it's a cyclical kind of process here. We can go to the next slide. All right, so what are co-occurring disorders? We just kind of pulled out some of the mental health conditions that people experience, I think largely experience when we talk about co-occurring disorders, and also the kinds of drugs that people are using. So a lot of, at the time in my work too, I would see, of course, anxiety, mood disorders. I personally have a lot of friends with ADHD who have turned to stimulants, substances like meth to just get by. I mean, I know when I was in college, people were selling their Adderall, right? Not only to make some money, but because it worked, it was effective. They were trying to cram for tests, right? But we don't talk about that, right? But we'll talk about people on the street who are smoking meth, right? Just to survive and stay up and not get their belongings stolen, right? We also talk about schizophrenia, which I think is deeply misunderstood, bipolar disorder as well, major depressive, which I touched on before, PTSD, and then switching over to substances, of course, alcohol, of course, tobacco, opioid stimulants. We talk about marijuana and weed. Marijuana, every time I see the word written out, I can't help but think about how the government basically devised this entire campaign to switch from saying cannabis to marijuana because they wanted to link it with the Latina and Hispanic community as a very racist way to target them. And if you don't believe me, just go back on history to the Marijuana Tax Act of 1934. So just a little history lesson in there for everybody. Hallucinogens and also prescription drugs. For folks who can't see, it's really, really tiny. I apologize. There's a very important note on here about the term misuse. A lot of times you'll see abuse, misuse kind of thrown out. We want to talk about how this can imply a moral judgment, right? About drug use and reinforce that stigma. So people use drugs for many reasons, like you all pointed out in the beginning. And I love that you said it wasn't just pain, 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 trauma, trauma, trauma. Like, yes, it's part of it, but it's also for pleasure seeking, right? Connection to reduce that isolation, right? And we know with harm reduction, our approach recognizes that drug use exists on a spectrum. And again, we're going to have a slide that kind of shows that in a little bit. And we're prioritizing reducing that harm, keeping people alive over that very punitive or abstinence-based or abstinence-only framework. Next slide. Because who doesn't love a good graphic, right? So I love the Venn diagram. You can't get much more simple than this, right? So we're talking about this piece in the middle, this overlap, right? Which I have to be honest, I think the overlap should be much bigger because I know 9 times out of 10, many of the people that I worked with, they were struggling, maybe didn't have the words for it. They didn't identify as a person who used drugs. They didn't identify as a person with a mental health condition. Some of them were younger. And we know that a great deal of mental health conditions are diagnosed in late adolescence or kind of this like young adulthood period. And many of them were just coping and saying, I got out of foster care and now I'm here and I'm jumping around. I haven't been able to hold a job and I don't have money and I'm borrowing this from a friend and I don't have a place to stay. And really just having a difficult time. So we can go to the next one. We have quite a few visuals. This is the one I wanted to get to. And to be honest, when I use this one in other trainings, it has a bunch of arrows jumping around. If I had a little laser pointer, I would move it around there. Because my point here is that our use in relation to use is not static, right? I think about COVID, right? I know so many people that during COVID, they were maybe using, I don't know, like socially, maybe they go out and drink, or maybe they go out and they'd like snort some coke or ketamine with people, kind of go out and have fun, but they were locked in, right? They couldn't leave, right? Because of protocols in place. So maybe they used a little bit more, maybe they bumped up to kind of regular use. And maybe it got to a point for them where it got a little problematic or got a little chaotic and out of control, and they didn't know what to do. Right. I will caution everybody, though, and say, and there's NIDA data to show this, basically talking about the fact that a very small proportion of people who use drugs actually result in having problematic or chaotic use. right? I think a lot of things get blown out of proportion. A lot of times in media, a lot of times in shows, right? Think about how many shows and movies you watch where people who use drugs, right, or people who are maybe struggling with their use are the punchline, right? They're not seen as heroic. They're not seen or shed in a positive light, right? So going back to this COVID example, maybe things open back up. Maybe people are going out, they're socializing again. They have to return to the office, whatever it is, and maybe they're reestablishing these connections, and all of a sudden they're dropping back to regular use, right? Maybe then it kind of goes to social or recreational use. I know things aren't always that nice and easy, but my point here is that we're not fixed. We're kind of moving along this spectrum here, right? Okay, we can go to the next one. Another one, again, we got a whole bunch of graphics here. But one thing I want to say is co-occurring disorders, right? They touch every aspect of our lives. It's not like we're just stuck talking about, educational opportunities. We're just stuck talking about issues with our job, right? We're talking about relational issues. We're talking about work with cognitive abilities, medical problems, right? Because we also know people with co-occurring disorders, we kind of saw in that video, there's also a higher chance of people being more vulnerable to chronic or kind of primary health conditions, whether it's, they can't access care, they feel too stigmatized to receive care, maybe the way they're treated, maybe they're misdiagnosed. I know that happens all the time. It's happened to very many people who I love in my life, where they've gone in for certain issues and the doctor gives them a different medication or kind of blows off their symptoms or whatever else, right? Maybe their trauma history, right? Their family dynamics, their spiritual life. And I actually don't know if I saw anybody say that with our first couple questions. Tanagra asked about why people use drugs and don't, but spirituality is huge, right? That's a huge overlap. A lot of times people will say, well, I use drugs because, it's a spiritual practice and I do this and I do that. Or sometimes people say, I don't use drugs because maybe I'm currently fasting and I'm not allowed to use because of religious reasons, right? So there is so much going on here. It's touching every aspect. And that's why our programs really have to meet those needs and adapt fully. I'm not saying, and please, I'm not saying that your whole facility has to open like a legal expertise wing, right? And have this whole like spirituality center. This is when you establish those collaborations and those partnerships with people in your community, right? You establish those MOUs with people who are hopefully values based, in alignment with what's going on with your organization, right? To be able to hand that off. Because again, this can be really overwhelming, but just to kind of show you the span of co-occurring disorders and what they touch here. You can go to the next one. All right, so this is really, really tiny. I'm not going to read all of them, but when we talk about harm reduction, we talk about public health, right? We're talking about approaches that view people through this human rights framework. And we talked about a lot of this when Tanagra was doing, what is harm reduction being the movement, right, within social justice, right, built on and around the needs of people who use drugs, right? This is also recognizing collaboration with people who use drugs and their lived and live experience. So this is incorporating a lot of what's in our 6 principles, which again, you can find on the website if you go to harmreduction.org, or if you just type into Google, honestly, principles of harm reduction. NHRC created them decades ago. Shout out to Carl Hart, amazing provider, harm reduction practitioner. Read his book, High Price. He's got a couple, but that one's excellent, talking about his experience. This is also talking about respecting autonomy and the right and the self-determination of people who use drugs, right? Talking about how this focus is also trauma and violence informed. And we're going to talk about this a little later, kind of moving from trauma-informed care, which is not a bad model, but we like to also talk about something called healing-centered engagement, which kind of levels it up, I'll say. So again, these graphics are just for you to have. You can hang up on your office, do whatever you need to. But again, just driving home the point that this really should be holistic, right? We're not going to get bogged down and stuck in this kind of clinical paradigm, if you will. Not that it's not helpful, right? But it doesn't tell the whole story, and people are not stuck in a vacuum. Okay, next slide. So this is probably one of the most important paradigms in all of harm reduction. Like if you If you just totally blacked out, you don't remember anything else, I hope that you remember this. And this I wish I knew when I was a very young case manager working at a clinic, because this would have explained so many things, and I think would have really validated a lot of the patients and the participants that I worked with. So I want to know who here has heard of the drug set setting model. If you've been to any of our like foundations of harm reduction, yeah, Freeway's got it. So there's this person, Norman Zinberg, who's a doctor, a social scientist. He developed this model, this drug set and setting model. So he wrote a book in 1984. It was called Drug Set and Setting, the Basis for Controlled Intoxicant Use. So he was basically challenging the dominant idea that drug effects are determined solely by the drug itself, right? So his argument was that a person's experience with a drug is shaped by a combination of these three factors. The drug, so that's the pharmacology itself, the drug itself, the set, so that's the person's mindset, the personal factors, and the setting, so that's like the environment in which the drug use happens, right? So when we talk about the drug itself, that's the chemical properties, the physiological effects of the substance. And we know that drugs work in a different way or in different ways because of how they affect the brain, the body, the potency, right? How strong they are, how long they last, or the duration. And this has gotten really complicated. And many of you have alluded to this in the chat with just how dangerous and how volatile our current drug supply is. And it's constantly changing. I know I see things over here on the East Coast that people are not seeing on the West Coast and vice versa. Or things people are saying, you know, I usually get this from my dealer. And it's not at all what they think, which is why we're big proponents of drug checking, you know, telling people to try to just use the smallest amount as possible, right? Because you can always do more, you can't do less. So just to kind of give some context there, right? So obviously with that, Zinberg emphasized that the drug alone does not determine the person's experience, right? So for example, two people can take the same dose of the drug, but depending on like their emotional state or their environment, they might have completely different experiences. So that's why when we talk about the set, or really the mindset, this is the emotional or the psychological state, right? So what are the person's expectations and their beliefs about how the drug's going to affect them? What are their past experiences with the drug? Have they used it before? Was it a positive or negative experience? Do they have mental health conditions? Do they have anxiety? Do they have depression? Do they have PTSD? What's their current mood? Are they upset? Are they happy? Are they feeling overwhelmed? So I tell people to think about psychedelics like LSD, right? So if somebody takes LSD when they're anxious or afraid, they're more likely to have a distressing experience, what people might call a bad trip, right? But if they're in a good mood, they're prepared, maybe they have a trip sitter with them, they're locked in, they're more likely, right, to have a positive and meaningful experience. And then the setting itself, that's where the drug use happens, the environment. So that's the physical location. Are they at a party? Are they at home? Are they in an overdose prevention center, right? Are they using with trusted friends, with strangers, in a supportive setting or in a criminalized setting? Are they using it in a back alley where the cops come by frequently? Are they using it in a place where there's bad lighting and all of this? Right? So all of this results in that outcome, right? Alexia, we're going to give you a copy of these slides, no worries. But honestly, if you were to type drug set and setting into Google, you'd see this all over the place. So again, before I pass it on, this is really driving home that drug effects are not universal. And also, I want to cut through that shame for a lot of people. If you're feeling like, I don't know why, I know this happened to me. I'm like, everybody else smokes weed. Why, when I smoke weed, I have like an absolute meltdown and I just get paranoid and my heart races and I can't sleep. And I'm like a total party pooper. And everybody's looking at me like that weirdo type A guy who can just never let loose and have a good time. That's because of my expectations, right? And I'm also using, or I had used with people I didn't feel comfortable with, right? And I put all these things on myself, and it wasn't necessarily the drug, but it was the set and the setting. And that resulted in a really different outcome than when I was at home with my partner, with my cats, comfortable, right? And I also want to really stress that this is why criminalization is so harmful, right? When we talk about criminalization, we talk about stigma increasing harm. This is a perfect example. If people are using, you know, by themselves, they're rushed, they're in high risk environments, trying to avoid law enforcement, right? They're at higher risk of ODing, or higher risk of infection, right? Because they're maybe not going through their normal process and thinking about all the steps and things they need to do, right? So yeah, if nothing else, drug set and setting, very, very important. I invite people to print it out, put it up in your little office or whatever. But yeah, so I think I'll pass it off to Nagra again for trauma.
Thank you, Taylor. I don't know how I did this thing, but somehow I have a pointer now. I
I
have no
saw
idea
that.
how that
I love
I don't
it.
know how that I don't know how that happened, but somehow I did that. It's one of those things. So I will have a pointer. So one of the things that when we're thinking of working with people who use substances who also experience mental health conditions, we want to acknowledge that the systems that they are embedded in terms of receiving services or looking for services can be very much traumatic for people. They're not systems that are set up for people to succeed. Many times they're systems that inherently are set up to be hostile to people and to really, again, only the strong can stay and weed out other people, right? Which is not at all what we want in a system. We want everyone to be able to access it and get what they need, right? And get what they need in a way that feels safe and that feels humane and that feels empathetic. And so we want to also name, right, that being trauma-informed or healing-centered informed is an extension of harm reduction work and can better set up us to be able to support our participants, our patients, our clients, and our community. So we want to share with you this definition from SAMHSA that speaks about trauma around these three things: the events. Let me put took my captions off. I'm going to put my captions on again because maybe they're wonky with my Spanish, my English accented Spanish, but I think it's better than nothing. Is the events, the experience of those events, and the effect of those events, right? And nothing is perfect, but for us, this is a definition that we understand can capture in a pretty robust way what the experience of trauma can be for people. So individual trauma, because we're going to look at trauma in terms of community experience trauma, but in a second, individual trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social-emotional, or spiritual well-being, right? So what SAMHSA is telling us here is like a person can have an experience that is derived from an event, a series of events or circumstances, right? And that to us, that experience is harmful, right? It's causing harm. It can feel life-threatening and can be causing harm in different areas of our life, right? It can be impacting our emotional, physical, social, emotional well-being, or spiritual well-being. Sorry, so for us, the experience is very much individual, right? And I always give an example of two friends that I have that had car accidents, kind of like 6 months apart from each other, pretty severe car accidents. And one of them, her response to their car accident was to get on a car the next day and start driving. Because for her, she was like, I need to do this immediately, otherwise I won't be able to get over it. And I have a friend the other friend did not get into it, like it won't drive ever again. It's like, no, I'm not driving. I'm walking, I'm taking the bus, I'm using my bike. I don't want to be in a car again. So same event, but two very different responses, two very different ways of experiencing the harms, right? And navigating and finding solutions, right, to address that situation. And so some examples of trauma that we have, and these are not the only ones, just some examples, because we know that this list can also be way more robust, is someone who has experienced or observed any physical, sexual, or emotional abuse, someone who has experienced neglect or abandonment as a child, having a family member that is living with a mental health or substance use disorder, mental health condition, someone who's experienced or witnessed violence in their community, or someone who witnessed that violence while serving in the military, right, or being abroad in another context, in another place. And when we're looking at poverty and systemic discrimination, these are some examples of trauma, right? Not limited to, again, we can potentially, we ask folks, we can add many other examples here. I would say being involved in systems that dehumanize us invisibilize us, stigmatize us, and mistreat us, right? That is an example for me of trauma. We can name those systems, right? But we also would be remiss if we didn't acknowledge that trauma doesn't happen only at the individual level, that there's structural, historical, and intergenerational trauma. And I think some folks mentioned that already in the chat, right? Communities as a whole can experience trauma, right? And we can begin mentioning communities here that are experiencing trauma. I just watched recently a documentary that was looking at the experience of folks that are survivors and grandchildren of Indigenous folks that had survived the boarding school system, which it's a bad way of naming what they did to Indigenous folks in this country and in Canada. And just, you know, understanding they just watching that documentary and trying to wrap my head around what this experience has been for generations for people, right? And that's just one example, right? If we take into account that Indigenous folks were pretty much forced out of their lands, out of their communities, right? That's just one example, right, of all their impacts that generations of Indigenous people are experiencing, right? And that's just one example of one community, right? We can think of other examples of other communities. I am Puerto Rican, and I will tell you that the collective trauma that we have as a colonized island that does not have the ability to make decisions, political, economic, social decisions for ourselves, and that we are pretty much subject to what another power determines for us. It's really horrifying. And I see other folks naming slavery, which is another very much clear, crude example of communities that have experienced this kind of trauma. Natural disasters experienced by communities is another example of trauma. I am from the land of the hurricane. So whenever June and July comes around, we start getting really anxious because that's hurricane season here. And we still have not recovered from 8 years ago from Hurricane Maria. And if you go to New Orleans, people in New Orleans still talk to you about Katrina. And they're like, we don't want to talk about Katrina anymore, but we're still dealing with Katrina. I don't know how many years, 2005, 20 years ago, right? It'll be the, yes, I'm sorry, freeway, absolutely. F you, Katrina, right? and people are still navigating with the gentrification and the effects 20 years of that after Katrina, right? And so thinking about fires in California, floods, tornadoes, the more that our environment is impacted by the policies that are just economic policies that are destroying our planet, and the more that we're going to see those things. Structural, historical, and intergenerational trauma is also rooted in circumstances that we inflict by one group on another. And here we see the war on drugs, stealing people's homelands. I was naming that before: forced relocation, servitude, slavery, mass incarceration, and ongoing exposure of trauma and violence in the community, right? When a community is constantly surveilled, right? It's constantly being persecuted. That is also the root of trauma. And we know that this trauma can be passed from one generation to another in a pattern that we know also as intergenerational trauma, that is also rooted in a study called epigenetics, that folks have been studying how that trauma is passed on from the DNA from one generation to the next. And there are books and studies that have been done on that. So just to name that, trauma is not necessarily only an individual experience, that there's also an aspect that is community-based, and that it's important to have them to account when we're working with people, right? That my trauma may be individual, but also is rooted in the experience of the community that I come from. And so what is trauma? We look at collective trauma, interpersonal trauma, and individual trauma. And here we can see all the different experiences or situations that can impact a person and create a situation of trauma for someone, from human trafficking to sexual violence, to domestic violence, to sexism, ableism, xenophobia, transphobia, homophobia, sexual harassment, medical trauma that I see folks have mentioned here and have been sharing their own examples of what they witnessed. And I thank you all for sharing your experiences so generously and openly with us in the chat, and helping us to think through these things together. Hate crimes, immigration policies, all of those things are part of the collective experience of trauma, interpersonal or individual trauma. And we cannot talk about trauma without talking about stigma, right? Because many times stigma impacts trauma and trauma also impacts stigma, right? And we respond with stigma to situations that people are experiencing that are rooted in trauma. And so what is stigma? Stigma is a concept that for me, if you have experienced that, you know what it is, right? You can feel it, you know it, right? Sometimes it's hard to articulate. And so it helps me when I'm thinking of stigma to have a visual cue, visually be able to sort of see it so that I can then internalize it. So stigma starts with ideas, right? It starts with stereotypes that we have about people, right? People who use drugs are incapable. People with mental health conditions are dangerous. People who have a substance use disorder cannot recover, right? So we start thinking about people in a particular way. And then we start believing those ideas. And those beliefs are prejudice, right? So from our head, we move to our heart, right? And we start feeling in our heart that they're scary, that they're shameful, that they're less than, that they're not trustworthy, that they're lazy, that they're criminal, that they're bad, that they are untrustworthy, all of these things, right? And so we have these ideas that we feel in our heart, and then we actually go into the actions. And what we see in society, that the things that the policies, the practices, that discrimination, those actions stem from those beliefs and those ideas, right? So we have to go back to the root, right, to analyze that and to understand where are these actions coming from. They're coming from these ideas and these beliefs that we have about people. And those actions, that discrimination, can happen in two different realms, the social realm and the structural realm. In the social realm is when we say or hear people say, oh, I don't want that treatment center in my community, or I don't want the harm reduction services program offering services in the basement of that church, or I don't want the harm reduction services van parked in the Walmart parking lot, or I don't want those kids going to the school with my kids, right? Or I don't want this person to be working with me. All of that NIMBYism, absolutely, yes, right? And then we have structural discrimination, right? And this is when we don't hire or support people, whether they have lived or living experience with substance use, lived or living experience with sex work, lived or living experience with mental health conditions. We don't have supports in place, education in place, right, for people that are working with those other folks, to be with those community members, with people like you and me, right? When we don't have equal coverage or equal opportunities for folks to be able to succeed and thrive in those spaces. And one example that I can give you comes from National Harm Reduction Coalition. And when our executive director, when Alan Clear, who was our executive director for many, many years, retired, a new executive director was hired. Her name was Monique Tula. And when Monique came in, like many other executive directors, she started reviewing all of our policies and all of our practices. And one of the things that she was reviewing was our health insurance coverage. And she realized that our health insurance coverage did not cover medications for opioid use disorder. And we have colleagues and friends in our staff who are folks who are need those medications and we're paying out of pocket to be able to have access to their medication, right? So our health insurance was discriminating against our colleagues, and we didn't know about it. And the sad thing was that they didn't feel that they could come up to leadership and say, hey, our health insurance sucks, it's not covering my medication. It would be the same thing as if it was not covering like my asthma inhaler or my heart medication, or I don't know if we in this country yet, or we're still covering any kind of reproductive I mean, like the pill or anything like that. I think at some point it was covered, but I'm not sure if it's covered. But, any kind of medication that a person needs, it doesn't matter, right? Like it should be covered. And so what Monique did was inquire and figure out and get a new policy, insurance policy that actually covered everyone, right? But we had to ask ourselves the question, why is it that our team members did not feel that they could say that out loud, right? Because of stigma, right? Because of stigma, because of shame, because of fear, right? Even within our movement, that is still there because it is in society, because it's so ingrained in the way that we see ourselves and we see people, because it is a social process, stigma. that reinforces those relationships of power and control, right? I still, as the ED of this organization, as the executive team, you make decisions, right? And you have power and control over my ability to stay employed, right? And there's that fear there. And it's a fear that I have, whether it's legitimate in the sense of another person acknowledging, that doesn't matter because it's a fear that I feel, right? And stigma also leads to status loss and discrimination for the person experiencing the stigma. We see the people who we stigmatize as less than. We see them as not human, right? And that's really dangerous. But because when we don't see another person in front of us as a human being, that's when really horrible things happen, and when human beings do really horrible things to each other. So stigma is the belief and discrimination is the action, but that belief is rooted in feelings. It's how we feel about another person in front of us, right? And that discrimination is the action, is what we see on the day-to-day that happens. And so how are stigma and trauma related? They're related because many times folks that are stigmatized are also experiencing trauma, and because folks that experience trauma many times may behave or show up in ways that lead to them being stigmatized because the person in front of them doesn't understand what's behind what I think is a problematic or a questionable behavior, right? So we really need to think about the fact that if we want to undo stigma, we also have to be willing to explore and understand the role that trauma has in a person's ability to move through the world. And we want to not cause harm to people, right? So we want to work from a place where we're questioning stigma, challenging stigma, and also looking at people's ability, right, to be able to recognize the situation that they have faced, and that they're not that situation necessarily, that there's how can we support someone to practice their autonomy, to reframe or restructure or reapalabrar, right? Like we say in Spanish, how do I reframe this event that happened to me, right? In a way that I can make sense of it, and that I can then see what I want to do with this moving forward. So I think this is where I pass it to you, Taylor. Correcto? Am I mistaken?
Nope, you got it.
Okay.
Yeah, time moves quickly. As always, thanks everybody putting all your comments in the chat. I'm also trying to answer questions. We are going to have a Q&A portion, but if you feel like we didn't answer your question to your liking, just let us know. We'll have time for all that. So as I alluded to earlier, so we have talked about trauma-informed care, right? And kind of how that doesn't always serve us, right? We're shifting from, we're going to shift from trauma-informed care in this section to later, we're going to talk about healing-centered engagement, or very shortly, because although trauma-informed care is great, right? It's very relevant to our work as providers, practitioners. We want to move people into kind of leveling up their understanding and really including those systemic and those kind of cultural barriers that are maybe not always brought into the conversation when we talk about trauma-informed care, right? So here we're shifting from what's wrong with you to what happened to you, right? So acknowledging that trauma is very widespread, as Tanagra just talked about, on those multiple layers and levels, and it really deeply impacts not only people's health, but their behaviors and their ability to access care, right? And for many people, trauma is not just a past event, right? It's an ongoing experience. That's one of the 3 E's, really shaped and exacerbated, in my opinion, by systemic oppression, violence, homelessness, incarceration, and medical discrimination, as we just heard about. And we know people with co-occurring disorders are much more likely to have experienced multiple layers of trauma, right? Including things like childhood adversity. I'm sure many of you are familiar with the ACEs scale, right? Social marginalization and criminalization. And I want to throw out there that instead of assuming non-compliance, which I personally hate that word, I know a lot of times in clinical care and practice, we're kind of forced to use these terms that are very stigmatizing and just ugly, in my opinion. Instead of assuming non-compliance, we should be recognizing how that past trauma influences how people are actually engaging with healthcare. So that's shifting our responses to center safety, to center choice and autonomy, and also empowerment. You can go to the next slide. So trauma-informed care, Again, it recognizes the presence of trauma symptoms, acknowledges the role trauma's playing in someone's life, including program staff. And I think that's something that doesn't get talked about a lot, but I hope that your organizations, or if not, you're thinking about it now, including some, trainings or just some time to really talk about burnout, talk about vicarious trauma, and talk about how these things really leach into not only our professional lives, but we carry it home with us as well. I know that was something I struggled a lot with when I did direct service work, which was everything up until 3 years ago in my career. And also, so our intent here with trauma-informed care is not to just treat the symptoms or the issues, right, related to whether emotional, physical, or sexual abuse or any other form of trauma, right, but to provide those support services, those holistic wraparound services in a way that is not only accessible, but appropriate and culturally appropriate, right, to people who have experienced that trauma. Next slide. So here is our trauma-informed perspective. And I love this, and I've used this in a few different de-escalation and conflict management trainings, because I think a lot of times the way we write reports or the way that we notate what's going on is inherently problematic, right? And we might not even see it. I know when I was working, doing more clinical work, I'd say, oh, that person, they're refusing to accept help, right? But maybe that person just has a lot of shame when we're offering them help or services and they've been doing everything on their own, right? And we're like, oh, we're writing them off now, right? Or we're like, this person is completely unmotivated, right? Maybe they have depression. Maybe they have serious anxiety or PTSD, and avoidance is a way for them to manage that discomfort, right? Maybe they're oversensitive, maybe they're reactive, right? And again, there could be there could be some kind of trigger that we don't see, right? Because we didn't take the time to sit down with them and get to know them. And also, we're not just going to get that overnight, right? There's going to be a shift that happens here. And again, non-compliance isn't on here, but that's like a big one for me, which really people, I think, are just avoiding care because maybe our services are not accessible. Maybe they had a bad experience with someone, right? There's also aggressive behavior on here, which has a whole nother layer to it because of the racial undertones there, where people would say that's a microaggression. I just think that's a straight up aggression, calling certain communities, namely Black and Brown communities, aggressive. So just pointing that out as well, because I've seen clinicians kind of throw that around with not realizing kind of the racial context there. So just trying to stay away from that. And really, maybe we're shifting to maybe someone is hypervigilant, right? Maybe they're always aware of threats. They feel like they have to be on guard or on edge because we're not making them feel comfortable, right? And I'm glad this is helpful, Lynn. I know, again, all these tools that we go over, now I'm like, I wish I had these things available to me when I was working with people, but we don't know, right? Which is why we're so glad that you're here. All right, we can go to the next one because we love another graphic. We'll break this down. So these are 6 core principles of trauma-informed care. I'm not saying this is exhaustive, but I think these ones really hit home what we want to touch on. So I'm going to kind of work us around clockwise. So safety. Safety is huge. I mentioned before, Tanagra has this great training on cultural safety, because I think that sheds a different light on what we talk about when we mean safety and what it means, not only for ourselves, right, as clinicians or practitioners, right, or providers, but also the safety of the people who we have the honor of providing services to, right, and our communal and kind of generational safety, right? But this could look like on the day-to-day, the physical and emotional environments that we create are welcoming and secure. I do a lot of that work. I had mentioned that I wrote a toolkit last year with another fantastic organization. The whole premise of that was to try to create more affirming environments for trans and gender nonconforming, non-binary people, right, who are doing sex work, who are using drugs, right, at our harm reduction programs, at our social service programs, because we're just not meeting the need, right? And for someone who's experienced trauma, these settings can feel really overwhelming. It can feel really threatening. So little changes, like even the lighting, my God, I would walk in the office, I'm like, I'm pissed off just because I hate, this this lighting in here, this fluorescent lighting, right? Maybe have something a little gentler, softer. right? Using non-judgmental language, as we talked about in the beginning, making sure that we're really practicing confidentiality. All those things can make a really big difference. Trustworthiness and transparency. So people who have experienced trauma, they often feel betrayed by systems of care. And we need to rebuild that trust, which can be really, really hard. But that means we have to be clear, we have to be consistent, we have to be transparent in how we communicate and make decisions. I know something that was hard for me was not always having the answer or the solution to everything, which is also symptomatic of, you know, just kind of the culture and society that we live in, having to have everything at, you know, the touch of your fingertips at every given moment, right? But it's okay to say, you know what, I really don't know, but is it okay if I check with someone, I get back to you? Or, you know, I don't have that resource, but I know somewhere that has it, right? So this means explaining procedures, you set those clear expectations and those boundaries, and you're honest about your limitations while you're centering that person's autonomy. Peer support and self-help, huge, really vital in trauma-informed care. People who have lived experience with, you know, drug use or mental health conditions, they can really shed some valuable insight and support to people who are navigating similar experiences, right? And fortunately, there's like a huge boon in kind of the peer support space. I know one of my coworkers, Jose Martinez, does this work with peer and really works on strengthening that trust and reducing stigma and just making sure people don't feel so isolated and they have that connection between one another. Collaboration and mutuality. So this is talking about shifting power dynamics so that providers and participants can work together as partners rather than enforcing this very rigid hierarchy, right? Where there's an inherent power dynamic of having the provider, you know, that white coat syndrome, stepping into the room saying, I know all the things, I have your lab work, or I have the services and I'm gatekeeping, right? And then that participant or patient feeling very powerless, right? When we co-create treatment plans instead of dictating them, we're respecting the patient's knowledge of their own needs, and it's going to make things a lot easier for you as well, because it's not a one size fits all thing. I think we know that. So empowerment, voice, and choice, this is really central because it just means that patients have a voice in their care, right? They have a choice. We talked about this when we talked about our own harm reduction principles, because too often people who use drugs or, you know, have mental health conditions, they feel like their choices are taken away from them. So our job is to provide them with information, with options. A lot of times we'll talk about harm reduction being a buffet, if you will. You know, just offering support so they can make those informed decisions and just have some agency. And the last one is cultural, historical, and gender sensitivity. So, you know, obviously needing to recognize how trauma is shaped by culture, by history, gender. We know that racism, xenophobia, homophobia, transphobia, and historical oppression, they create conditions where, you know, certain communities experience trauma at much higher rates, and Tanagra gave some really good examples of that. So trauma-informed care is understanding these factors and adapting our care to be a lot more affirming and to be a lot more inclusive. You can go to the next one. So the 4 R's of trauma-informed care. We have the 6 principles, we have the 4 R's. So realization, so realize, recognize, respond, and resist re-traumatization. So when we talk about realize, this means understanding that trauma is really ubiquitous, it's widespread, and it deeply impacts health outcomes, behavior, and engagement with care, right? Like I said earlier, it's not just an individual experience, it's often systemic and intergenerational, right? We talked about things like racism, poverty, incarceration, medical neglect, they all contribute to this trauma. And this in turn influences how people access healthcare. And then we go to recognition or recognize, right? We're talking more about how trauma manifests in someone's behaviors, right? Their emotions or coping mechanisms. To use that example earlier, a lot of times trauma responses get misinterpreted as non-compliance or someone being difficult. But maybe there's distrust of providers or just the medical industrial complex. You know, emotional outbursts, they might be a trauma response, not a sign of someone trying to defy you. And a lot of times we know that drug use is a way for people to cope with that stress, right? Hypervigilance, anxiety, withdrawal, dissociation, these are all very normal responses to past trauma, but they can be easily misread or highly stigmatized, right? People say, oh my gosh, are you hearing or seeing things? Instead of just letting that person kind of rock with it for a moment, right? And not making them feel shame about it. So third one is respond. So this is how we actually integrate trauma-informed care into our practice. So that's why we say, you know, shifting from what's wrong with you to what happened to you. Avoiding that re-traumatization means reducing these power imbalances, right? Avoiding coercive treatment, and making sure that someone's autonomy is actually respected, right? So we're avoiding those rigid, those punitive approaches, requiring sobriety for care, right? That can really re-traumatize people and you might lose them entirely. I know when I worked my last job at a syringe service program, there was a local hotel that unfortunately now it closed because of a bunch of bananas, a bunch of NIMBYs, right? Who didn't want people who use drugs and homeless folks to live near them, God forbid, right? And so many people left the hotel when they, you know, they had the option of having this room, but they had to get rid of all their drugs. And they were like, well, that's, you know, I spent good money. And so you would see drugs flying out of the windows because people would go and get rid of them. And then, you know, somebody else would catch it and run off with it. And it was a whole thing. And I'm like, this is so much drama and fanfare of just being able to say, hey, we have a locker, we have a place, right, where you can keep things, keep your items, and then you can retrieve them on your way out, right? But a lot of these programs just had a strict policy. And I'm like, what do you think? People are going to walk in the door and completely just alter everything about themselves. It's just not realistic and it makes no sense. And we're re-traumatizing people. Next slide. So moving from trauma to healing. So healing-centered engagement, right? This is an approach to address trauma that requires a different question that moves beyond the what happened to you. If you were kind of like, well, that doesn't seem like enough. It's not. What's right with you, right? We're going more strength-based. We're going more positive here, and views those exposed to trauma as agents in the creation of their own well-being rather than victims of traumatic events, right? So giving agency, ownership, and this is really a key principle of harm reduction too. If you think about it, right, this releasing ownership over other people's choices. You know, our role as providers is to support and not control. Next slide. I love this. I love this graphic. So this is Sean Ginwright's 5 parts of healing-centered engagement. So kind of just going around and talking about, you know, it's in culture, right? Healing-centered engagement acknowledges that healing is deeply connected to culture, to spirituality and community, making it a lot more inclusive for historically excluded groups. I wouldn't even say marginalized. Let's be intentional, right, about what's going on. Also integrating joy and agency, right? So trauma-informed care primarily focuses on mitigating that harm or trying to allay that harm, right? But healing-centered engagement is actively seeking to try to cultivate that joy, that hope, and that sense of purpose, I think, as part of the healing process, right? And honoring any positive change, we talk about that a lot in harm reduction. That's really critical, right? If someone switches from injecting by themselves to using maybe with a friend who can administer naloxone or Narcan if they need to, that's a success, right? Even if that person is injecting alone and they have the number for safe spot, right? That's a huge thing as well. I think somebody asked in the chat and said, you know, well, what do I do if I can't say never use alone? Ask them what their safety plan looks like, right? That's a really big moment of saying like, hey, do you have a safety plan? If not, let me offer to help you with this, right? What are some things we can incorporate into this? So anyway, just a really nice graphic to kind of center healing-centered engagement. Can go to the next one. So healing-centered environments. So we talked about this a lot with drug set and setting, but I think it also comes into this when we talk about healing-centered environments and healing-centered engagement, because the environment that we build or that we create for the people coming in to receive our services, that really communicates our beliefs about the people we serve and also has a big impact on the way that we actually go about offering those services. I don't know how many of you, but if I go into an office, like I'll never forget, I went to, I think I had to get like a gynecological exam, and I got sent to like the women's center of whatever. And as a trans person, it was so traumatizing. And immediately it was hit with like the Venus of Willendorf, statue and vulvas everywhere and all these things. And then like, people my mom's age sitting in there wondering why a man is coming in, and just that says so much, right, about the way that I was going to receive services. Unfortunately, it ended up working out, but I did leave a comment on the survey just saying, if you're going to take trans people, you might want to chill with all the vulvas and the Venuses and all these things going on. But that was probably the most apparent situation in my life where I was like, I feel so uncomfortable. And I'm a person that's really, really hard, if you haven't noticed, to make uncomfortable. So I think just understanding what it feels like to be in that person's shoes, right? To feel welcomed, right? A sense that people want to have us around, that the environment is set up in a way that makes us feel like we can fully engage and bring ourselves to the table. Because a lot of times when I was doing or providing these services, I can tell I wasn't getting all of that person, right? Because think about how highly stigmatizing a lot of the questions and the intake forms are, and we're expecting everyone to tell us all these things that they wouldn't even tell maybe their partner or their best friend. That's bizarre, right? Next slide. All right, so my question for all of you, and I know you have opinions, I see them. How can a trauma-informed approach be helpful when working with participants experiencing co-occurring disorders? So given everything that we have talked about today, what comes up for you here? How's this helpful? Danya says, recognizing triggers. So we have a lot of Detroit, Michigan people. I love the networking. Keep at it. Peer support settings. Love that. Makes them feel safer when people get it. Understanding their reasons for use a lot better. Yeah, it guides us to approach participants with curiosity versus judgment. Yep, non-judgmental. It's a big theme coming up. Yes, encouraging participant autonomy. Look at you using the principles. Naomi, people are often working, oh my gosh, I'm losing it. There's so many, working in the context of multiple overlapping stigmas. Yes, I'm seeing a lot of non-judgment, self-autonomy, right? Meeting them where they are, what they want and what they need, right? Show more care. Yeah, it's all of these things, right? I'm not looking for any one answer. I think if anything today, we learned that it's not a one size fits all, right? We have to really customize our approach, and it can be really difficult because we work in these very rigid kind of clinical or clinically bound programs that have all of these diagnoses and all of these protocols and all of these frameworks. And again, I think a lot of it's very well intentioned, but we lose sight of the focus of the person in front of us, right? And that's just something, if anything, I want people to take away. And really, too, what I was trying to harp on with drug set and setting is, again, people are going to have very different experiences. They have very different experiences of maybe a traumatic event, but also of their drug use and also of their mental health conditions. If you have people who you're like, yeah, I work with people with bipolar all the time, don't just assume that everybody's going to show up, with that diagnosis the same way, right? Because there's a lot of stigmatizing thoughts and behaviors that people, place on folks with bipolar or with different mental health conditions. So just keeping a very open mind, right? Okay, next slide. And we're almost done here, folks, and then we'll open it up for questions. So again, harm reduction really gives us freedom. Practicing the harm reduction principles that Tanagra went over in the beginning with the trauma-informed care principles, right? With all of these pieces and our lovely graphics and all these things we have for you today is really allowing us to release that ownership over other people's process and their outcomes, right? And it allows us also to see things in a more positive light and honor those positive changes. And to also, as many of you said, you're centering the person, you're centering the autonomy and the self-determination of that person. You're giving them the tools and the options. Remember the buffet analogy, right? That they need to be able to just thrive, right? And maybe if they're not at a point where they're ready to thrive yet, because there are so many barriers and so many things going on, to survive. We want you here. We need you here, right? How can I make that happen? How can we work and cultivate a safety plan together? Next slide. So my questions for all of you, and you can answer these in the chat or you can write it down or think quietly to yourself, but can you identify one thing that you or your organization is already doing that's in alignment with harm reduction trauma-informed care. Oh, sorry, Tanagra.
I'm sorry,
Or-
both it.
It's okay. Or healing-centered practice. Can you identify one thing that you're already doing? And if you're not in an organization, it's okay. You can answer this as an individual as well, right? Yep, meeting folks where they're at, peer-led community model, doing trainings on this. Christine, I love it. Honoring any positive change, radical kindness. I love that, Leanne. Person-centered language. And people are like, oh, person-centered language isn't all of it. But let me tell you, folks, it goes a long way. The way that you first interact with someone, that first impression and the words you use, even if nobody's telling you, they can hear the way that you're talking about certain communities of people. I know for a fact, like, again, when I was working case management, we had cubicles, right? Which, oh my gosh, was not confidential at all, but people could hear one another in the way that they would talk about clients. So they would talk about people who use drugs, right? People living with HIV and AIDS, queer and trans people, all of it, right? It makes such a big difference. Uplifting and empowering women at your agency. I love that. Compassion, not judgmental. Community navigation services so you can connect with people on different levels. I love that. Yeah. And then also, so on the right here, I have another question for you. What's one thing that you can change today about your practice and environment to make your services be more harm reduction, trauma informed, or healing centered aligned? And this might be difficult to answer. You might feel like you have all the things, you know all the things. It can be one small change. It doesn't have to be a huge thing. Yeah, Randall says unconditional, really living that unconditional positive regard. Language. That's real, Emily. Rashawn says, I'm printing the drug set setting diagram for our staff and exchange room to keep it in the front of mind. I love that. Training the frontline staff. Yes. Using appropriate terms and notes and discussions. Yep, that's huge. Because remember, folks, too, a lot of those documents, they can be subpoenaed, right? So the way that we talk about people, we want to be aware, right? Those documents. Adjusting language. I see a lot of that. And that's a fairly easy thing to shift. I mean, it takes a lot of repetition, but I think if you do that in concert with a lot of your staff or a lot of the folks you're working with, it becomes a lot easier. Or if you kind of have signals up and around, right? If you print out posters or flyers that talk about, we're going to commit to using person first language to really center our folks, it makes things a little bit easier. Yeah. Taking cues from our participants.
Taylor, while
Yes,
we
no, go
get
ahead.
other, so that we can then share with folks the slides while we continue to hear from folks.
Absolutely. Amazing. And how many people still have, we have 365 with us. Oh my goodness.
And Harmony, if you, I think some folks had asked some questions in the Q&A, so I would like to maybe like go first through those questions, and then we can move to other folks that wanna chat with us.
Sure, yeah. So it's on the bottom. I think most folks can see it. Correct me if I'm wrong. There should
Let
be.
me see. Q&A, I see it there. Okay.
So the first question we have is, can you give an example of a different definition of abstinence?
Oh, absolutely. So for some folks, abstinence may mean refraining from use from all substances. For other folks, abstinence may mean refraining from using a substance to which they have identified they may have a complex or problematic relationship with, right? So for some folks, their definition of abstinence is I am going to not use heroin anymore because I feel like I no longer like or enjoy, or I no longer want to have a relationship to this substance, but I can still drink alcohol or use cannabis, right? And for some other folks, it may mean I don't want to use any substances at all whatsoever. So each person probably will have a different perception of what abstinence is. And I think my invitation to all of us is, again, to work from a place of curiosity and really allow the person to define what abstinence means and can look like for them. Thank you for that question, Amber. Hope we answered it. And then what are some signs if someone is using or that someone is high? Well, that will depend on what the substance is and on the person, right? And their tolerance, etc. I think that if we are looking at opioids, there are some signs that we can look at in terms of you know, in order to help us address if that person particularly may be experiencing an overdose. And we have a training for that. And also we have some resources on our webpage that can help us identify potential overramping, which is an overdose on methamphetamine and stimulants, because there's more than one way to overramp. And they're also an opioid overdose. Let me see.
So I think there was.
Go ahead, Taylor.
I was just gonna say, give you a break. You're on a roll. So Lynn asks, I've been wondering, can repeated use of drugs such as cocaine or heroin be counted as trauma events? It's a really interesting question. So, and I would love other people, you know, to type in the chat. My interpretation is, so what I always tell people is that drugs are inherently neutral, right? Drugs are neutral, but what happens is that they can cause things like dysregulation, right? They can cause dysregulation of a stress response. You know, if someone's using them chronically, I think especially with stimulants like cocaine, right? Or maybe even meth. I think about, you know, prolonged fight or flight activation. They can kind of heighten that dopamine, those adrenaline levels, right? Keeping people in that heightened stress state. I also think about, you know, people being exposed to harm and violence. Maybe somebody is selling drugs and maybe something goes awry, or maybe there is a situation where there's police brutality going on, there's incarceration happening, exploitation. So my point here being is it's not the drugs themselves, but it's the systemic kind of circumstances around the use that might be not the answer that you want. But I think that's the way to contextualize it. We really have to put it in the frame of what's currently operating, going on around us.
Yeah, and I also wanted to uplift something that Conrad mentioned related to that in the chat, which sometimes if we're not engaging in a compassionate use of naloxone, it can be more harmful to program participants. I think regardless, an opioid, when someone is reversing an overdose, it can be traumatic for the person reversing and also for the person coming back. So it's so important our bedside manner when we're reversing an overdose. The person may be confused coming back. They may be angry. They may be frustrated, scared, right? So it's always important to welcome them back and say, hey, you had an overdose. I am here to support you. You are okay. Please hang out with me for a couple of minutes. I administered naloxone. I administered this dose or this many doses, right? So that, you know, they are aware, because if they go out and use again, it could be more dangerous for them, right? Because, you know, the naloxone is still in the system, and so they're in withdrawal. So I think, Conrad, you're right. You know, it's how we respond to that, how we apply the naloxone, but also how we respond through the process that can make a huge difference. And that's a trauma-informed healing center engagement harm reduction perspective. So thank you for naming that. Let's see. We have other questions here. The pillars of trauma-informed care. I think we mentioned most of those pillars through our session, but I think it's centering the person's experience, looking at people as human beings from a place of empathy and caring curiosity, right, without judgment, and really trying to understand what that person's experience is like in life and why they may be showing up in the way that they are. For me, are pillars of trauma-informed care. I don't know, Taylor or Harmony, if you want to add anything else that I may be missing.
Yeah, no, I think you hit them, and fortunately we have it as a graphic. So we had talked about, you know, safety, trustworthiness. We talked about collaboration, empowerment, voice, what Tanagra's kind of talking about, peer support and mutual self-help, and also the cultural, historical, and gender issues there.
Thank you, Taylor. John, I really appreciate your question. And I think what I would love for us to do is you'll have access to our slides and you have access to our emails. I think that if it's okay with you, I would love to connect with you offline to chat more about your question about in terms of like which are the ways that we can continue to support community in the midst of what we're experiencing and seeing. And I think it's just like, I want to give that conversation the room and the time and the depth that it deserves. So we would love to have it. And you have our email so we can connect. Moving forward, we can have a conversation. So please don't hesitate to reach out and we can find a time to connect and talk more about some of the things that we at NHRC are doing, but also to hear from you. And if there are other folks that are interested in that conversation, and reach out to us, and maybe we can get a small group of folks together to discuss it. The other thing is, I don't want to lose any of the resources. I know Harmony has been doing a really amazing job of collecting those resources. And what I want to do is, if folks are okay with it, create a Google Drive folder where we can put those resources in that will be open. So you can also add other resources. So it's a community folder of resources that we can all have access to. So if that's okay with folks, maybe we can set some guidelines. So give us a minute so we can make sure that, when we're accessing it, we there's some, everybody knows what to expect from the process, and then we can share with you. But we are collecting those resources so they're not going to get lost. I just wanted to name that. And then Freeway. Ooh, this is a great question, Freeway. When the presentation is done, can you give an example of what it might look like to hold space with someone experiencing reality that isn't widely accepted? Can you give some example of dealing with NIMBYs and maybe a couple of suggestions of effective ways to get around dealing with neighborhood associations? This is a current issue I'm dealing with and could use some suggestions. Freeway, where are you located? Could you share with us your location? I think it'd be helpful to know where you're based out of. I think I saw it was in the West Coast, but I don't want to assume.
Freeway, if you want to raise your hand, I can also allow you to come.
Yeah. Oh, there you are. Hey, Freeway.
Hey, sorry. So I'm actually in Oakland right now, and
Okay.
one of the big pillars of the work I do is harm reduction, but it's harm reduction through the lens of housing justice.
Yes.
The group that I'm with is a grassroots organization that formed by the unhoused community that was swept from Wood Street. So what we're dealing with right now is we've got these solutions that are like alternative, and I'll try to make this as brief as possible. But basically, all of the solutions that have been being used so far have been very ineffective and very costly. And there's these neighborhood associations that are sort of they're trying to work with us, or we're trying to work with them, however you want to look at it. But one of the big issues that keeps coming up is their stigma surrounding RV dwellers, and and specifically the drug use that they are that they're supposedly seeing, which I have my beliefs about anyway. But that just keeps coming up as like, oh, all the RVs are drug dealers and this and that and the other, and that's obviously not the case, because for other reasons. But how do we navigate that conversation, and how do we create that environment where I can say to them without cursing them out that they're full of shit? You know what I mean?
Yeah, absolutely. Are you connected at all to West Oakland Punks with Lunch?
Yes, they're
You're
like
working together?
Yes.
So I think Ale has been sort of like also thinking more broadly in terms of how to address that. The other organization that I would connect you to, because they experienced a similar situation across the bridge in San Francisco, and it's you may know them, Homeless Youth Alliance.
Very, very well. We used to receive resources from them. Yes.
Yeah, I think Mary has been dealing with exactly what you're saying. And I think that if you feel comfortable, I would just, and Eliza, Eliza Wheeler from Remedy Alliance for the People.
I'm familiar with the first name you said. Well, I can't remember what it was now.
Mary Howe. Mary Howe.
Yeah.
Mary Howe. Yeah, Mary who's AD. Also, Eliza, I think both of them, if you would like, if you can share your email with us, I'd be happy to connect you to Eliza, because Eliza ran for 2 years during their camp, which was a safe space for folks that were living on outdoors in the midst of COVID. And they had to address exactly what you're saying, how to deal with this community, sort of like neighborhood-based organizations, where you have some folks that are supportive, but many other folks that may oppose for different reasons. And I think they may have some strategies that they can share with you.
Okay, and also real quick, because I am on the move now. I'm actually on my way to another meeting as well. But I had a more personal question, and again, I'll just make this as brief as possible. You spoke about gray areas earlier with harm reduction, and there's one in particular that keeps kind of coming up. One of my dearest friends, I consider him a brother. is in San Francisco. He is unhoused, and he is also currently still using. And his health has deteriorated to a point that I don't recognize him anymore. Like, I physically can't recognize him. And he, yeah, I'll just leave it at that. It's very, very poor health. And I'm dealing with the dilemma of, as a harm reductionist, I'm about, meeting somebody where there's at, and all these other principles, and I live and breathe that every day. But I'm really struggling right now with not just like kidnapping him basically, and like forcing him to come to my house, and even just recuperate, like not necessarily quit using. I'm not even going that far out, just like
Yeah.
doing something to help him recuperate, because I feel like I'm watching him die, and I don't know how to navigate that.
Freeway. I just want to say, please, thank you first of all for sharing that with us, and sharing. That's really hard, and I'm sorry that you're going through that. And I think many of us also, as harm reductionists, practicing harm reduction with people that we love or with family sometimes can be really really challenging, right? Because it brings up all these other feelings and emotions that are very complex. I'm just so grateful that he has you, and that you want to be there to support him. And I think maybe continuing to show up for him and have conversations with him, and maybe explore, in a way that he feels safe with you, about what is going on and what you're seeing. You can say what you're seeing. You can love someone and still name what you're witnessing, right? From a place of love and care. And ultimately, I know that you will respect his choice, and you'll be there for him. And at the same time, I think that it'd be really a really honest and como se dice, brave thing to do, to also name with love and care that you're concerned, that you're seeing that some things may be happening, and that you want to be there for him, right? And maybe raise that concern from a place of love and non-judgment, like I know you will. Maybe can give him room to feel safe having that conversation with you. We're holding you and him close to our hearts, Freeway. Thank you for
Thank you
sharing
guys
that.
so much, and thank you for this training.
No, thank you. Thank you. Our other folks, I can hang out for a couple of more minutes. So if Sharonda and Leslie, you still are around and you wanna share some thoughts, and then we have some questions here in the chat that we'll try to respond as we go forward.
Yeah, we have so many questions here. My gosh.